You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about intra-aortic balloon pumps, or IABPs. This episode features more practical type knowledge beyond what will be tested on the boards, including pearls about how to troubleshoot common balloon pump issues in the CCU. Let's start with the basics. What does the intra-aortic balloon pump do? During diastole, the IABP inflates, displacing blood toward the proximal aorta, which enhances perfusion to the coronary arteries. During systole, the rapid deflation of the balloon creates a vacuum-like effect, reducing aortic volume and afterload, thereby decreasing the workload on the heart. Benefits of inflation during diastole are: inflating the balloon during diastole increases blood flow to the coronary arteries, enhancing myocardial oxygen supply and improving coronary perfusion. Benefits of deflating the balloon just before systole are: it reduces afterload, which decreases cardiac workload and myocardial oxygen consumption. This reduction in afterload also improves cardiac output by making it easier for the heart to eject blood into the aorta. What physiologic effects does the balloon pump have? It improves cardiac output and perfusion. By inflating during diastole and deflating just before systole, the balloon pump increases diastolic blood pressure and reduces systolic blood pressure. This enhances coronary artery perfusion and overall cardiac output, leading to better oxygen delivery to end organs. It reduces pulmonary capillary wedge pressure. The balloon pump decreases left ventricular end-diastolic pressure by promoting more efficient LV emptying, which lowers the wedge pressure. This effect helps reduce pulmonary congestion. It decreases left ventricular wall stress, since the left ventricle will be pumping against a lighter afterload. It enhances peripheral and renal perfusion, improved cardiac output, and reduced afterload to increase capillary filling, leading to warmer skin temperatures due to better peripheral perfusion. Additionally, enhanced renal perfusion results in increased urine output, indicating improved kidney function. It also lowers heart rate. By optimizing myocardial oxygen supply and reducing oxygen demand, the balloon pump can decrease the heart rate needed to sustain oxygen delivery. This reduced heart rate further supports the heart by reducing the myocardial workload. So, to recap that part, the physiologic effects of the balloon pump are that it improves cardiac output and perfusion, reduces pulmonary capillary wedge pressure, decreases left ventricular wall stress, enhances peripheral perfusion and renal perfusion, and improves urine output, and lowers heart rate. Why is helium used? Helium is less dense than oxygen at room temperature, allowing rapid inflation under laminar flow conditions. If the balloon leaks, helium is rapidly absorbed into the blood. What are the indications for using a balloon pump? It is used in patients, most commonly, with cardiogenic shock in the CCU to provide hemodynamic support. It is indicated for refractory unstable angina that does not respond to medical therapy to improve myocardial oxygen delivery and reduce ischemia. It provides hemodynamic stability during complex PCI, including left main PCI, especially when there is a risk of hemodynamic compromise. It is used for pre-surgical stabilization in patients undergoing CABG to optimize hemodynamic status preoperatively. It can help in acute mitral regurgitation or ventricular septal defect secondary to acute MI by reducing afterload and improving forward cardiac output, and it serves as a bridge to transplantation for patients with severe heart failure, providing temporary circulatory support while awaiting a heart transplant. What are the absolute contraindications to balloon pump placement? Presence of severe aortic regurgitation, which will be worsened by balloon inflation. Aortic dissection, where the balloon's inflation could propagate the dissection, and patient refusal of the procedure as informed consent is necessary. What are the relative contraindications to balloon pump placement? Patients with existing iliac artery stents or iliofemoral grafts or stents, as the presence of these can complicate the placement and function of the balloon pump. Abdominal aortic aneurysm, which poses a risk of rupture with balloon inflation. Septic shock, where the hemodynamic support of balloon pump might not be effective due to systemic vasodilation. Severe bleeding disorders, increasing the risk of bleeding complications from the procedure. Severe bilateral peripheral vascular disease, which could obstruct balloon pump insertion or cause further vascular complications. And sustained tachycardia with heart rates greater than 160 beats per minute, as rapid heart rates limit the effectiveness of diastolic augmentation by reducing diastolic filling time. What precautions are needed for balloon pump patients? The head of the bed should be kept flat or at an angle of less than 30 degrees to minimize the risk of catheter migration and ensure optimal functioning of the balloon pump. The leg on the side of catheter insertion should be immobilized to prevent movement that could dislodge the catheter or cause vascular injury. Percussion vibration modules should not be used in patients with a balloon pump, as these could disrupt the proper functioning of the balloon or cause displacement. The balloon pump should not be left in standby mode except for very short periods, less than 3 minutes, while troubleshooting or evaluating the possibility of weaning the patient off the device. Prolonged standby can lead to thrombus formation in the balloon or catheter. What force sizes do balloon pumps currently come in? 50 centimeters cube or 50 milliliters. These balloons are for patients taller than 6 foot. 40 centimeters cube for patients 5'4" up to 6 foot. 34 centimeters cube for patients 5 foot to 5'4", and 25 centimeters cube for patients shorter than 5 foot. So the most common one you're going to use is 40 centimeters cube or 40 milliliters. Where should the balloon pump be on the daily chest x-ray? The balloon's top notch should be at the level of the carina and inferior to left subclavian artery, or 1.5 centimeters to 2.0 centimeters below the aortic knob. What should you watch out for in patients with a balloon pump? Sudden changes in augmented pressure. This may indicate incorrect timing of balloon inflation and deflation, which could compromise the effectiveness of the balloon pump and reduce hemodynamic support. Decreased urine output. This may indicate balloon migration downward, potentially obstructing the renal arteries and impairing renal perfusion. Decreased peak augmented diastolic pressure. This could indicate that the balloon migrated away downward from the optimal position in the aorta, thus diminishing the effectiveness of diastolic augmentation. Loss of left radial pulse. This may indicate that a catheter has migrated upward, potentially obstructing the left subclavian artery and compromising blood flow to the left arm. Abdominal distension, bloody stools, or abdominal hypertension. This may indicate mesenteric ischemia, which may occur if the balloon obstructs flow to the mesenteric arteries. The 6 P's of the ischemic limb: pallor, pain, pulselessness, poikilothermia, paresthesia, and paralysis. These signs indicate limb ischemia, which may result from compromised blood flow due to balloon inflation or arterial obstruction at the insertion site. And lastly, watch out for blood in the balloon pump tubing. This is a critical sign of balloon rupture, which requires immediate attention to prevent further complications such as gas embolism or vascular injury. Now let's focus on interpretation of balloon pump numbers and waveform. The assisted systolic blood pressure is the systolic blood pressure measured when the balloon inflates and assists the heart during systole. The unassisted systolic pressure is the systolic blood pressure measured during a cardiac cycle when the balloon does not assist, meaning the balloon is not inflated. Interpretation: the assisted systolic blood pressure should be lower than the unassisted systolic blood pressure because balloon inflation decreases the afterload the left ventricle has to overcome to eject blood. This reduction in afterload facilitates easier ejection of blood, thereby reducing the systolic pressure required. The assisted end-diastolic pressure is the end-diastolic pressure measured after balloon deflation. The unassisted end-diastolic pressure is the diastolic blood pressure measured when the balloon is not inflated. Interpretation: the assisted end-diastolic pressure should be lower than the unassisted end-diastolic pressure due to reduced aortic pressure after balloon deflation. This reduction in pressure helps decrease myocardial oxygen demand and preload, aiding in myocardial perfusion. To better understand these concepts, you're welcome to download the handout on balloon pumps from my website. Moving on, diastolic augmentation is to increase aortic pressure during diastole when the balloon inflates. Interpretation: diastolic augmentation should exceed the systolic pressure because it represents the combined effect of systolic pressure plus balloon inflation. It represents the primary mechanism by which the intra-aortic balloon pump improves coronary perfusion by increasing diastolic pressure and thereby enhancing coronary blood flow. The goal is for augmented diastolic pressure to exceed unassisted systolic pressure by at least 20 millimeters of mercury. The dicrotic notch is a small upward deflection in the arterial waveform immediately following the closure of the aortic valve. It is used as a cue for balloon inflation. Goals: for the balloon pump to be effective, you want to pay attention to two numbers. Diastolic augmentation, you want that to be at least 20 millimeters of mercury above the baseline systolic pressure. The assisted end-diastolic pressure, you want that to be at least 5 millimeters of mercury lower than the unassisted end-diastolic pressure. Now let's talk about trigger modes. There can be ECG trigger, pressure trigger, pacemaker trigger, or asynchronous. In ECG trigger, the balloon pump deflates at the peak of the R wave and inflates at the middle of the T wave. The reliability of ECG trigger, of course, decreases during AFib or poor ECG quality. Pressure trigger inflates and deflates according to the arterial pressure waveform via fiber optics or transduced via the sheath side port. Pacemaker trigger inflates and deflates based on ventricular spike. It is appropriate if the patient has a 100% pace rhythm. Asynchronous, it inflates and deflates at a set rate of 80 beats per minute, that's internal trigger. Only used if there is no cardiac output, such as a cardiac arrest. It is important to know common problems with a balloon pump timing and how to troubleshoot these. If you see early inflation, that is inflation before the dicrotic notch, that means diastolic augmentation is encroaching onto unassisted systole, losing the dicrotic notch. This will cause premature closure of the aortic valve, increase in LV end-diastolic volume, LV end-diastolic pressure, and or pulmonary capillary wedge pressure, increase in LV wall stress or afterload, and increase in myocardial oxygen demand. The treatment is to delay the onset of inflation until the dicrotic notch reappears. If you see late inflation after that dicrotic notch, that means diastolic augmentation is unable to reach its peak pressure, causing inadequate coronary artery perfusion. Treatment is to move the inflation onset earlier until it inflates at a dicrotic notch. If you see early deflation and suboptimal diastolic augmentation, that means diastolic augmentation is unable to reach its peak pressure. There's a sharp drop following diastolic augmentation, causing suboptimal coronary perfusion, potential for retrograde coronary and carotid flow causing angina, suboptimal afterload reduction, and increased myocardial oxygen demand. Treatment is to prolong the duration of inflation so it deflates at the end of diastole. If you see late deflation and widened diastolic augmentation, that means assisted end-diastolic pressure is ending up even higher, which is bad, than the unassisted end-diastolic pressure. The rate of rise of assisted systole is prolonged. This causes absent afterload reduction. The IABP is impeding LV ejection, thus increasing the afterload, and this increases myocardial oxygen consumption due to the LV ejecting against increased resistance. The treatment is to shorten the duration of inflation so it deflates at the end of diastole. What should you do if the balloon pump patient goes into asystole, such as in a cardiac arrest? Definitely start ACLS, including chest compressions. Switch the trigger to arterial pressure, which can be generated from chest compressions. If chest compressions do not provide an adequate trigger, then change the control to internal trigger. You want to keep the balloon pump catheter active so that clot formation is minimized. Set the rate at 60 to 80 beats per minute and the frequency at 1 to 2. Turn the balloon augmentation down to 50%. What do you do if the patient goes into AFib? Well, treat the underlying cause of the AFib. What do you do if the patient goes into irregular tachycardia? If the ECG trigger is suboptimal, then use pressure trigger, and definitely treat the underlying cause of the tachycardia. If the patient goes into VT and can't keep up with 1:1, change the ratio to 1:2. Cardiovert and defibrillate as appropriate per ACLS. The balloon pump console is electrically isolated, so it is okay to defibrillate or cardiovert a patient who has a balloon pump. What do you do if you suspect a balloon pump perforation? Check if there's a loss of augmentation. Helium may be leaking from the balloon catheter. Set the alarm limit so the alarm sounds with a drop of 10 millimeters of mercury in augmentation. Check if there is blood in the balloon lumen tubing, suggesting perforation. It is possible for a balloon leak to be self-sealing as a result of the surface tension between the inside and outside of the balloon pump membrane. Check for an abnormal waveform. There will be no waveform if the balloon is unable to retain helium, or the pressure plateau may gradually decrease if the balloon pump is leaking helium. What do you do if there's indeed balloon pump perforation? First, place the balloon pump on standby to prevent further balloon pump pumping. Clamp the balloon pump catheter to prevent arterial blood backup. Then, disconnect the balloon pump catheter from the balloon pump console. Remove the balloon catheter within 30 minutes. If the balloon pump leak seals itself off, this may result in entrapment of the balloon pump in the vasculature. So that is very concerning. How do you wean a balloon pump? First, do a weaning trial. Change 1:1 to 1:2. Ensure hemodynamic stability in about an hour. Then change to 1:3. Ensure stability for an hour. Then change back to 1:1. Stop the heparin and wait until ACT falls below 180. Gather your suture removal kit, gauze, tegaderm, gloves, and mask. Identify the femoral pulse 2 to 3 centimeters above the balloon pump insertion site. Palpate or Dopplerize the DP and PT pulses distally, and explain the procedure to the patient while you're doing this. Place the balloon pump in standby mode. The balloon will deflate. Retract the balloon through the sheath until resistance is felt once the balloon encounters the sheath. Once this occurs, remove the balloon and sheath as one until both are fully removed with one hand while the other hand is above the hole. Allow 1 to 2 seconds of bleeding to allow for any thrombi to be expelled. Apply focused pressure to the femoral artery site and hold pressure for 30 minutes. Apply gauze and a transparent pressure dressing, and maintain a leg in a straight position with strict bed rest for 4 hours. Assess the distal pulses to ensure that they are present. That's everything I wanted to tell you about intra-aortic balloon pumps. Again, this episode features more practical type knowledge beyond what will be tested on the multiple choice questions on the boards, including pearls about how to troubleshoot common balloon pump issues in the CCU, so I hope this was useful to you.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.